So welcome to our 2023-2024 Big Data AI Hub Summer Series, our speaker series here at the Institute for Management and Innovation. My name is Irene Wysek, and I am a professor of accounting and director of the Big Data AI Hub. As always, our goal with the seminar series and other activities of the Big Data AI Hub is to engage our stakeholders in conversations about big data, AI, and other emerging technologies across different areas, disciplines, and industries. We're focusing on AI in this part of the series. And last session, we discussed use cases for Chat GPT and generative AI. This session, we will turn our sights to AI in healthcare, a very front of mind topic as we move hopefully out of the pandemic and face new healthcare issues in Canada. Do we need to take a blank sheet approach to healthcare? How can AI and emerging technologies help us rethink things? Once again, my special thanks to Professor Michael Marin for lining up our next eminent speaker. Excuse me. Before we introduce our next speaker, just a reminder that this session is being recorded and will be available on our website after. We encourage you to ask questions by raising your hands or putting something in the chat, and we'll do our best to get to you. Today, we're going to have a little bit more of an informal approach. We don't have a PowerPoint presentation, but it'll be a little bit more conversational. And so feel free to engage however you would like. For today, we welcome Dr. Adam Kassam from Toronto Metropolitan University, where he is the founding executive director of Health and Innovation. He is a professor and past president of the Ontario Medical Association, and he was past president during COVID, so that was a significant role. And he also has a very active practice, so that's incredible as well. So we are totally thrilled today to have Dr. Kassam with us. And with that, I will turn things over to you, Adam. Adam?
Thanks so much, Irene, and thank you so much for the invitation to be at this speaker series. I will admit not to have a PowerPoint presentation, and hopefully we can have a pretty open and frank discussion with the group. I'm happy to field questions sort of ad hoc or at the end, but just to give you a brief primer for the audience and who I am. I wear multiple hats, but first and foremost, I'm a clinician, and so I have an active clinical practice. I'm a physiatrist. No one knows what that is, Irene, but basically it's a physician who focuses on the rehabilitation needs of folks who've had muscle, bone, and nerve injuries. So we think about folks who've had strokes or spinal cord injuries, brain injuries, catastrophic injuries, amputees. And so we sort of deal with a lot of the rehab needs that come with it. And my practice is sort of broadly based in Ontario. I have an inpatient practice at a West End GTA hospital where I see predominantly hip and knee replacement folks, as well as a lot of geriatric rehab. And then I'm in approximately 30 long-term care homes where I do a clinical procedure for a condition called spasticity, which is a neurological condition that can develop after any upper motor neuron lesion that can lead to tight muscles. And so that's sort of the clinical side of things. On the sort of leadership side and on the technology side,
Oops, we've lost you there.
Oh, sorry. I
was just going to say, while you're doing that, you look too young to do all that. Oh my gosh.
Well, I feel, perhaps I feel older than maybe I look, but I can tell you that, and Irene, you know this, we welcomed a 6-week-old, we have a newborn who's now 6 weeks old, and he didn't have a very good night last night. So I'm trying to be as coherent as possible. So forgive me if I get off topic a little bit, and you can reel me back in. But so that's the clinical side. The leadership side, most recently I'm the past president of the Ontario Medical Association. I was president during 21 to 22, which was really in the heart of COVID. And you can imagine, just to give some context, the Ontario Medical Association is a membership association that represents close to 47,000 physicians across the province. Our main responsibility as part of the organization is to really negotiate on behalf of physicians with the Ministry of Health as far as physician services and the agreements that come therein. But of course, with the pandemic, which really upended all of our lives, including everyone on this call, We were very involved in things of policy, of advocacy, things like vaccine rollout, et cetera. And so it was very much a chaotic and a crisis moment for everyone in healthcare. And to be able to be at the helm of the OMA at the time was certainly a challenge, especially given the political and other rhetorical contexts that we were dealing with. Why this is relevant for a group that cares about AI and technology as it pertains to healthcare. During my term, we negotiated what was called the Physician Services Agreement, which is the second largest line item in the provincial budget under the Ministry of Health. And it was approximately a $45 billion deal that spans 3 years. So think of all the physicians that are paid through OHIP. That was sort of the deal that we negotiated. But why this is relevant on a technology side is that for the first time ever, as a result of the pandemic, we, through this framework, were able to negotiate virtual care as part of this. And so when we think about, I'll talk a little bit about this as a broader sort of experience, but why this matters from a technology perspective. Obviously, virtual and digital care really, ballooned or blossomed in and through the pandemic, and there are many reasons why historically the adoption rate was so low, but also how now things have changed as far as clinical practice and all of the digital tools that will come as a result of this framework that is also now being negotiated and adopted, by the way, nationwide through provincial negotiations right across the provinces. So that was sort of my work that I did over the past several years, and most recently, I've been recruited by Toronto Metropolitan University to help with some of their healthcare innovation and strategy initiatives. Most saliently, I would say, is that there is a medical school that we are establishing and standing up in the next 2 years that will be located in the Peel region in Brampton. It's already been announced. There's funding that goes with it from both the provincial and municipal levels. And you can imagine any work that requires the standing up of a medical school, whether it's recruitment of clinical staff or, and we can talk about digital and data governance and privacy and all of those things in a few moments. But these are very, very significant heavy lifts. The other component, and that's part of my work. My portfolio is a bit more broad than that, but what and Irene and I talked a little bit about this earlier. Part of what I'm been brought on to do as well is to establish a center of health innovation and equity, and that will sort of be housed in a physical bricks and mortar physical campus in Brampton that we're going to be sort of architecting to basically be a health innovation campus that includes, and there are many examples of this, whether it's accelerators, whether it's Mars, et cetera. But the biggest, and I'll sort of bring sort of policy into this at a later point, which is to say the biggest difference here is that this campus will actually be one where there is service delivery embedded in it, meaning patients are going to get care at this location in addition to all of the other elements that we're going to bring and bolt on, which I think is part of what our initiatives are. So that's sort of a broad thematic of what I've been doing in the space that I've been involved with. But I know that this is sort of a conversation about data, about AI, about potential for how technology will and continues to be disruptive in healthcare. And I think that we're sort of at a tipping point in our sector, which is that where in the past there's been perhaps a lot of friction or resistance, I think we're now seeing that technology, and fortunately, will continue to be and is now going to be leveraged as being, I believe anyhow, one of the key ingredients for success for healthcare system transformation, for integration, for digital and data, and then ultimately for all of that in the service of better patient care and outcomes. And, I think that over the past, call it 3 or 5 years, that we've really been probably honed in on thinking about healthcare in maybe a slightly different way, obviously because of the pandemic. Obviously, things need to change. We need reform in some capacity. This needs to be a coordinated and broad approach, both at a federal and provincial level. But certainly the pandemic has focused us on the challenges that our unique Canadian healthcare system has. And, I think it's not surprising to anyone on this call that we live in and unfortunately operate in a very siloed space in medicine. And so in the past, it used to be, right, you had a family doctor who had a bricks and mortar sort of mom and pop kind of family practice, and they had their charts on a wall. With you run into their doctor's office, and they had a wall of these these file folders, and it was like thousands of them with all those the stickers on the sides, and they were like blue and red and green and all those things. and believe it or not, there are certainly practices that still exist on that bandwidth or on that framework. But obviously, things have shifted a significant amount throughout the pandemic, and obviously since the way in which we've practiced clinically. But where the challenge remains is that your family doctor who might be now on an electronic medical record, so the migration of all of those records now digitally, that system might not speak to the system that is based in a hospital, which might not be, and often not communicates to the physiotherapist clinic that you have to go to because of a rotator cuff problem, or the X-ray that you got at an X-ray ultrasound suite is not connected to the provider downstream. And so what we're finding is that these silos, which are very strong silos and hard to penetrate, I will tell you, how do we bring those things together so that we can have some unified opportunity to coordinate care, to integrate care, and then of course all of the data that can then be mined and used effectively. That's, I think, where we're at right now. We understand that there is a lack of integration. We know that there are hundreds of entities out there that are in operation, that are that are doing their work of housing data and clinical information. How do we have a framework? Do we have policy? Do we have governance? Do we have even legal structures to I don't want to say break down those silos, but at least connect those silos as best as we can? If you were, and if we were building a de novo system from the ground up, and Estonia is probably a good example of this. And in fact, some of my colleagues in Turkey have been doing this with quite a lot of success as well. But if you were building a healthcare system, at least thinking about it from a digital or data perspective, you would never have, 100 different vendors, 100 different systems, all of our major hospitals on different health information system record systems. That wouldn't happen. It wouldn't make any sense. But we have this fragmentation. And I think that at least in the Ontario context, is going to be hard to unwind. So this concept of having a unified sort of one digital system, I think in Ontario is somewhat of a pipe dream. I think stakeholders are entrenched. I think there are business and private interests that have staked out their market in many ways. And so I think that there is an oligopoly of players that will not sort of relinquish some of that established territory. And so what that then means, at least from my vantage point, is rather than saying we're going to roll up everything into one, which is going to be extremely hard because data privacy and ownership already exists and it's very, very hard, as I said, hard to relinquish. How do you then just integrate? So how do you get the information flowing from one system to the other? Can we create highways between these silos and these destinations so that data can be shared, even though it might not necessarily be under one umbrella? So I think that's kind of where we are sort of as data is concerned. Other systems have it different. So if you go to Alberta Health Systems is all on one kind of record system. And that's an amazing thing to have. Believe me, it's an incredible thing as a clinician to be able to just have a note or have the record system available to me so I can know my patient's last data, their last x-ray of their knee or their last blood work or their last ultrasound, et cetera, and maybe what the medication change happened at their pharmacy. And so that's, on Alberta Health Services done a substantial job, and is probably a national leader in this kind of work. What's interesting though is Alberta has 2.5 million people, and Ontario has close to 15 and growing. And so I think that we have to understand our context. And Irene, you and I were having a discussion before, which is to say that we always look to the United States as being this terrible system. And full disclosure, I spent 10 years in the States doing my undergrad in medical school and a master's. So I think that we can take good things from other systems and try and apply them to ours. But in the United States, they similarly have this fragmentation with the private interests that are much more entrenched. But we shouldn't try using an application of 350 million people of a country that's 10x our size with a very different system and try and apply it into our context. The application is a little bit more challenging. And similarly, when you look at Alberta, well, they have 2 million people and we have 15. It's going to be hard to unify just based on what we have in our space. So why do I say all of this? I think that our focus moving forward on data and digital really needs to be focused on integration as opposed to saying unification. So integration over unification. That I think, for me anyhow, at least from my vantage point, is a better way to think about getting to a better place than where we've come from before. We don't need another white paper to say, oh, we should have a unified healthcare system. Like, yes, we all know that. It's just, so operationally, well, how do we get to that point, and what are the stakeholders, and what is the mandate of some of our work? Which brings me to sort of to my next point, which is, we're trying to stand up at this medical school, and we're having clinical partners, but you can imagine, so for example, we're recruiting clinical partners and clinical sites that are both hospital-based and community-based, but all of them are on different healthcare health information systems. And so, we're not going to be able to come in as an entity and say, you know what, why don't you just upload everything to one and we'll be done with it? Like, that would be a non-starter for a lot of those folks, right? Or a lot of our stakeholders. So is there a way then to, as I said before, establish a network where information can be brought together or shared? And that's where the role of public policy, of government, of private enterprise, of health institutions like this, and AI hubs like yours, are going to provide a lot of value add. Now, so that's where we need to go. And before we can get to that better point, I think what we need to, and I don't think that this has happened yet, is to establish a framework for data governance. So data stewardship, data privacy, and data security. Okay, so those four elements I think are very important. When I was OMA president, we were on calls with our counterparts in Newfoundland. And in Newfoundland, they have a unified healthcare system on one system. Once again, it's very luxurious to have that kind of opportunity, and they're a smaller province. But what had happened about 3 months into sort of the pandemic being declared was their entire healthcare system was hacked. So essentially, it was seized by nefarious malware actors. I think it was either Russian or Chinese nefarious actors that basically held this entire healthcare system for ransomware. And so you can imagine, these are, and all the geopolitical challenges that we are facing, digital infrastructure is now becoming a critical target for some of that geopolitic proxy warring that we're finding. Why do I bring this up? Is, again, for data security and contingencies. What had happened in Newfoundland was no one could access any records. People who had, for example, a cancer screening or an X-ray or an ultrasound for cancer, who had their reports uploaded to the system and read by radiologists, no one could access that. So now you can imagine, if you went for a test as a potential cancer patient, you had your records being seized, no one knew how to get them back, and no one knew what your actual diagnosis or prognosis was. People would have to get, the solution was get people rescanned, but you can imagine that there was already a backlog of 6 or 10 months of this because of COVID and others. So, these are, material impacts on the health and well-being of our citizenry, which is also, which ironically, building in the redundancy in Ontario by having the fragmentation makes it somewhat more secure than having it housed in one area. So there are, unintentionally, maybe on the security side, things are better. But all to say, just to bring this back sort of under one theme, digital governance. Who owns the data? We don't have an established understanding right now. Right now in Ontario, it's really the physician provider who owns the medical chart, but obviously there are patient advocacy groups and others and policymakers who want to sort of change sort of the dynamic to have data ownership be more broad-based. The reason why that's very valuable is, if you can imagine down the road, this has happened, I think, with companies like 23andMe, the genetic testing, the genetic company that does genomics and personal genomics. When you sign up for 23andMe, you basically sign a waiver that says the data that they collect can actually belongs to them, and they can do with it what they would like. And a lot of that data is now being sold to big pharmaceutical companies to mine data and to find personalized pharmaceutical genomic therapies for conditions. Why does this matter? I think having a framework for what data ownership looks like in our country and in our context is going to be very valuable and important to get right before we sort of launch into this sort of big data and AI and precision and large language models and predictive medicine. So we need to start with fundamentals, first principles. Let's get the governance right, because this is now an expanding field that is exponential. The second, of course, is the infrastructure and funding. So let's say we now have, so taking a step back, and I apologize, this is a bit all over the place, but taking a bit of a step back, the Ontario Medical Association, which obviously I was a part of, has 3 subsidiary companies that are wholly owned. One of which is called Ontario MD. Ontario MD was initially set up by the provincial government, the Ministry of Health, as a flow-through agency or entity to encourage physicians to migrate from paper charts to digital charts. So much like in the United States in 2010, under the Affordable Care Act, also known as Obamacare, they gave significant amount of money to physicians to adopt technology because they recognized that this was an additional cost to individual providers and private, small business owners. Essentially, that's what they're private contractors in our current structure in our system. But that money was given to them in order for them to buy the technology and have it as a subsidy for their cost. Similarly, Ontario did the same thing and said, here's Ontario MD, we're going to roll through all this funding and allow physicians to migrate onto a digital system. But in so doing, at that point in time, it was understood that if the physicians were the ones purchasing from the vendor, if they were the ones that were inputting all of the data, if they were the ones that were actually using that data, then that data belonged and it was owned by them. And so that has to be somewhat untangled or at least shared as a cost and revenue and an ownership model that we have to get right before we can get to the next place. So we talked about data governance, who owns it, who owns the infrastructure, so who is then supporting the purchasing of the technology, the upkeep of the technology. Is it if I'm a physician and or a nurse practitioner or a physiotherapist clinic and I'm paying TELUS to keep the lights on my digital side, should I be subsidized by that if we're going to have a shared ownership model for this? So data ownership, data infrastructure, and then of course overlay that which I've talked about, which is security and privacy. So I think on the privacy side, I think HIPAA laws probably need to be modernized. I think that's something that we need to think about. So people would say, like I would say, and I have patients who say, oh, I don't really care if if someone looks at the x-ray of my knee like that, I don't really care about that kind of privacy, right? But, if we think about mental health, if we think about, other stigmatized sort of areas, that kind of personalized sensitive information can actually be weaponized. And so we need to figure out a way that the privacy in the context of our new data environment is modernized to keep up. And I think that's where the federal and the provincial governments have a role to play, because that really is legislation, right? That's legislation. It's healthcare law. And I'm not sure that we have had a fulsome conversation about how the legal language should change. What are the applications of the law in the context of a new and changing field that is very, very quick to adapt? So that's sort of the digital and data kind of infrastructure and the sort of 4 key elements that I think about when we're thinking about our healthcare system. Let me sort of bring this to somewhat of the relevance of sort of AI and predictive models. Like obviously, Chat GPT has taken everything by storm. Large language models, you're looking at Bard now for Google, and obviously there's multiple competitions. This is now, and you look at what NVIDIA has done in terms of its AI. Now its market cap is like over $1 trillion on the New York Stock Exchange. So Chat GPT, AI, large language models, predictive modeling. And we're at the tip of the iceberg. It is going to have a disruptive and major impact on our healthcare system. I'll give you a couple of examples of where I think that might be relevant. So, on the one hand, let's look at 3 different buckets. We can look at like system, provider, and patient, right? If we think about our healthcare system, so let's think about like system, patient, and provider. So on the system side, you can imagine where if you have an opportunity to bring all these threads of data together, and Ontario Health and the Ministry of Health probably, I would say, as a jurisdiction, probably have amongst the largest data sets, maybe anywhere in the world, but at least amongst the most diverse in the world in Ontario. Like Ontario Health and Ministry of Health have an incredible amount of data. And the question is, how do you use that data in a good way, ethically and morally, but also how do you make it more relevant? So you can imagine a situation where you can take all of that data and apply this language and predictive model and look at outcomes, both retrospectively and prospectively. To look at how to better screen someone for heart disease or diabetes or chronic disease like cancer, um, and whether or not your treatments are working. So if someone in a certain environment gets screened at a certain age with all these other interventions, and you look at their sort of medical comorbidity outcomes, are they better or worse than other environments that followed a different path, or in a different sort of resource environment, or perhaps their genetic makeup was slightly different, and so you can use all of that to not only better prevent or screen for disease, you can then allow it to come to a point where you can better treat for disease. So should we be treating, and this is something that's happening right now, which is, and this is sort of in the healthcare space, a pretty controversial topic right now, which is screening for breast cancer. The Canadian guidelines say 50, and now there's a push to say 40. The reason why people are saying that 40 should be the new normal is that a lot of ethnic women actually experience breast cancer at an earlier age, and so you should be screening earlier. So imagine you could predict who would be actually at a higher risk for having a cancer, and therefore they could go through a screening protocol that would be different than someone's perhaps at a lower risk based on your prediction from all of this epidemiological data that you had. In my line of work, where I see a lot of, I'm on the sort of the opposite side of the spectrum, which is I see a lot of geriatric patients, I see a lot of folks who with disabilities, I see a lot of people who will come into our hospital but can't get home because now they're 85, they have osteoporosis, they fell, they had a fracture, they had a surgery, and now their mobility is an issue. They can't get home because they're a widower and they have stairs and they can't climb up the stairs. So now they're waiting for a bed at long-term care, but now that wait list is now 2 years. And so how do they languish now before being able to get to a better place? Imagine you could predict who was at a higher risk for having a bad outcome, whether it's a fall or whatnot, and going upstream and saying, you know what, maybe we should subsidize that person to have a chairlift in the house, or maybe we're going to get them in home nursing in advance, or it's going to be available if this permutation happens. And in so doing, you actually allow more efficiency through the system. So now this person is not languishing in a bed in a hospital that they don't need, which is now creating upstream backlogs of getting into the hospital, so being admitted for something like a fracture or whatnot, which is why your emergency wait times are 24 hours, right? So thinking sort of along the value chain, this has a huge opportunity to unlock efficiencies, to unlock unrealized value in our system. So this is where all of that data is going to be very, very powerful on the prediction side, on the prevention side, on the intervention side, and on the rehabilitation side. All through the value chain, this is going to be very, very valuable. And it has to happen right now because our boomers are getting older. We have this great tsunami upon us. We're seeing this actively in this space. And so this is how we need to figure out a way to use that data and digital in a leveraged way to improve outcomes, improve the quality of care, improve the provider experience, and ultimately improve our system at a broad level. So that's kind of where I think that sort of Chat GPT kind of predictive for data that exists is very valuable. I was on a call recently with a couple of colleagues, and one of our colleagues was saying how they had seen a patient and they were confused by a possible differential diagnosis. Like they didn't know where this, they'd ruled out some of the big and bad stuff, but they didn't know this person was still having issues. They'd done some workups, but they didn't know what else could be problematic just because, it was a bit of a strange presentation. So our colleagues actually inputted some of the data, or like the de-anonymized data, into Chat GPT, and Chat GPT within 30 seconds provided a differential that was, incredible. And so not only it not only produced a differential diagnosis, but it provided a treatment pathway for each of those different diagnoses. So if this, then maybe go and screen for that. If this, go and screen for this. And this is the future, right? So there is absolutely no way any single human being can continue to have that much knowledge and expansion and at their fingertips. It's just not possible. Like that, our computational bandwidth is just not. It's not at that level of Chat GPT. So the way I see sort of medical education, medical diagnostics, prognostication on treatment plans, how these are going to be developed is going to be through the application of a lot of these large language models and to our clinical practice. So you're going to still need a doctor, but the doctor might not necessarily need to know, the first 30 different differential diagnoses, because it's almost impossible to really keep that all in your mind. It's going to be, how do you prompt? How do you leverage this technology through understanding of prompts, of access of data, of access to that knowledge, so that you can then guide the patient through that experience. I think that's where we are headed. We're not there yet, but we are going to get there pretty quickly. And if you believe in Sam Altman and all the folks doing the AI work, not that this is a runaway train, but this is going to, like, we're just at the delta between now and, let's say, 3 years from now is going to be so substantial that we need to start thinking about it yesterday on how we're going to actually integrate this into our healthcare sort of environment. So I think that on the AI side, that for the provider and patient, you're going to start seeing more broad understanding of disease through the leveraging of technology, which can then also scan all of the latest information that is public or that is published in medical, research sort of libraries. So you'll have not only all of the past data, but you'll have all of the current and possibly future data at your fingertips, and very, very powerful. And then I'll sort of tell you sort of a nuts and bolts kind of thing that we're also kind of dealing with in our sector, which is, healthcare burnout and so health human resources challenges, people leaving the profession, people scaling back, people scaling down, people not wanting to be involved in this kind of environment anymore, or not having the bandwidth to do so. And so one of the biggest issues for physicians and for healthcare providers is this notion of documentation. Okay, so right now there are legal requirements to document every visit that you have with the patient. There are certain requirements, and oftentimes now with an EMR, you use the EMR to sort of do that work. So you can imagine it. Maybe some of you have already been to your family doctor or another physician. A lot of them will be on, they'll sort of kind of you'll be seeing them, but then they'll also be on their computer, and they'll be typing away, and then that'll sort of be part of that experience. And it's probably not the most ideal environment when you're trying to deal with the patient, deal with their needs, but then also document this, and then have to do everything else on the administrative side. That's where technology and AI is going to have a huge effect. So there are multiple companies, for example, now, which will do sort of auto AI scribing. So let's say you can imagine now where I'm sitting with a patient and I'm doing my exam and I'm talking with them, and we have the EMR with this chat widget on it that is receiving that oral information through that conversation, perhaps can even see it through video, and it will be able to auto scribe my note, my documentation, and possibly even predict what kinds of treatment plans I might want to consider, and then operationalize them. So if it's all in an EMR, and I need to, let's say, so if I see someone who has a bad knee, I want to probably get them an ultrasound, or actually depending on their condition, possibly an MRI or a CT scan. I probably want to give them possibly a medication, maybe an injection. I might want to send them to physiotherapy for a brace and for range of motion and stretching and all of those things. They may need to see a surgeon for an ACL rupture repair or a meniscal disease treatment plan. So, all of that would be able to be done automatically, as opposed to me having to go through that patient record, that encounter, then record it, and then send it away. So there are already companies that are doing this sort of auto scribing that will shift the burden of that admin onto a technology, and then free up and unlock the physician-patient relationship, which is much more valuable. And it's funny, my wife, who's a physician, her and I were chatting, and we're saying how we're leaning into this technology, and eventually you might end up just seeing like a chat bot, right, for your healthcare needs, or at least for your screening protocols at some point. And at some point, we're actually going to get back to a point where people are going to want to see other humans in person. So you're going to see this pendulum swing, because you're going to see technology be leveraged in such a significant way. But there is something very valuable about a human connection and a human touch, that people are going to pay a premium to have the technology, but also speak to a human and be, that in the room with another person, just because of the fact that humans are so social, and we see that the value in that. We saw that during COVID with lockdowns and separations, right? So all of that kind of work. So that's sort of like where I think some of the buckets of AI is going to sort of really be leveraged. It's going to be on the system. So how do you predict, reorganize, integrate care? On the provider side, it's leveraged technology in order to ease administrative burden, ease some of the menial tasks, ease some of the things that are of low sort of value for a physician or a healthcare provider. We didn't go to medical school. People didn't get into healthcare so that they could just type on a computer. That's not really where that value for them is. And so shunting all of that stuff to another to the technology and allowing for that human interaction for treatment and for care, that's going to be really valuable, I think, for the provider. And then finally, for the patient, in an idealized way, you're going to get better care, faster care, more integrated care, more personalized care that actually delivers value, is possibly on demand, right? And that's sort of the again the holy grail for our patients. So, in Canada, look, we struggle with wait lists, we struggle with funding, we struggle with access, we struggle with high quality, sort of like latest and high quality technology for our patients. We sometimes fight for the lowest common denominator. But I do think that we're at a point where not only the public and the system is demanding change, but we are at a point also where we have an opportunity to really succeed in leveraging technology for the better. So I know that's sort of like an up, down, sideways roller coaster, probably stream of consciousness for a lot of folks and hard to follow. And I apologize, a little bit sleep deprived, but I wanted to give you a sense of sort of where we are, where we possibly might go. What are some of the tools and areas of interest that we probably need to think about? And we didn't really talk about this, but we have to at some point, which is funding models, payer systems, things that are sometimes thought of as taboo, but really I think are rolled into at a higher level federally, sort of this concept of modernizing our Canada Health Act, and can we make it more nimble, more attractive, more relevant, and more, I would say, just salient for the current and future states of our healthcare system. So Irene, that's kind of
Wow.
a meandering, probably somewhat disorganized talk.
No, that was incredible. And I think you give us hope that there's a way forward. So thank you for that. And the work you're doing
absolutely
is incredible. It's incredible.
Look, I think I'm a glass half full kind of person, and I think we need to look with optimism to the future. We've had some struggles. It's easy to get down on ourselves, but I'll tell you, I mean, think about where we were. Listen, I remember 2 years ago when I was OMA president during COVID, and this is when at the height of Omicron, when Omicron was just peaking and just cresting. I mean, people were in a really dire strait. And so look where we are now. Look where we are now, and so we are at a much better place. They developed vaccines in less than a year that was then deployed to the entire world. Like, it's just phenomenal what we can accomplish, and technology is going to put this on an overblast, right? Like, we're gonna see such tremendous change that I think is very exciting, and I'm optimistic about our future.
Yeah, absolutely. And we have to use those technologies such as generative AI to augment our human intelligence. Like, it can supercharge us, right? So I got two questions while people are thinking.
Sure.
Number one, you mentioned 23andMe, and I actually have 23andMe. And what I like about it, and I want to ask you your thoughts on this, is that it sort of shifts. I know in the medical community, you talk about patient-centered care and health, but to me, it's a little bit more like it allows me to take more responsibility for my own health if I have the data, right? I'm not saying, okay, my doctor is in charge of my health. No, I'm in charge of my health, but I need the data so I can see the patterns, because the richness and the patterns that you can see once you get your data together, that's an incredible, powerful thing. So then I can start to think about what it means for me, right? If I have the data. So what are your thoughts about that? Do you think that there's going to be a shift to more people, given the data and the access to their own data, taking better charge of their own health?
I certainly think that there is absolutely a trend, and that trend will continue in earnest, in my opinion, that people will not settle for not having access to their own personal health information data. Like, they're going to say, these are my genetic, this is my test, this is my own well-being, and this is my future and the well-being of my family. So I think the Overton window has shifted from sort of not a, I don't want to call it sort of a hierarchical or patriarchal kind of sort of system, but yes, giving patients the agency, the ownership of their own health is going to be very, very powerful. I think where we have to figure out a path forward, which I think will be complicated, is, at least in the Canadian context, is can we make sense of data? Can people make sense of their own data in the right ways? Can they be educated to understand what may be relevant, what may not be relevant? How do you do that? And can we use technology to help finesse some of that understanding? And I think that all answers to that are yes. And so you can imagine, if let's say someone has 23andMe and they think that they may have some predisposition to some chronic disease, and they might want to say to their doctor, "Go get me a test." But in our Canadian context, we may have, and frankly, we have a scarcity of resource, right? Unless, and again, this is on the system and funder side, which I think needs reform, and that's a whole other conversation. But you can imagine that people are going to be, perhaps demanding services of a system that perhaps don't have the bandwidth or capacity to do so. And so the question is, how do you square that circle? Do you allow people to then say, you know what, I'm gonna vote and pay with my own credit card, right? And I'm happy to do that because this is, I care that much about my own health, and we have a system for that. Or is it the opposite, which is to say that we create a system where the relevant information is pursued, the relevant information is actually understood, and then that can actually be brought into the system so that they're not ending up in the emerge, or they're not ending up with a bad outcome that then costs 10x what they would have done if they had gotten that test 10 years ago. So I think that the answer to that question is yes. I think that there's going to be more power in the hands of consumers of health data, which will be personal. I think that yes, there will be more demands on the system to unlock opportunities to address those issues upstream. And then I think for policymakers and for our health system leaders, how do you meet the demands of a growing and an aging population that will demand better service? I think what you've started to see, look, boomers, largest intergenerational wealth transfer in the history of the world. Boomers have been very successful. They have money in their pocket. They're willing to spend it, and they're willing to demand. They're willing to also vote. And so I think you're going to start seeing that shift in consumer thinking that will also influence our healthcare system. Yes.
And just one quick one then to follow up, you mentioned the education. I think that's critical, that we actually teach people about data and how to, deal with data. And so you mentioned in the medical education, we're struggling with this in accounting education as well, like how to transition us from being the keepers of knowledge. And I think in medical, you're the same, like what are those 20, diagnostics, or what pass forward. But you talked about the doctor as a guide and using things like generative AI or whatever that can gather all the data and the most up-to-date data and synthesize it and look at all the research and whatever very quickly. But then you still need the human doctor as a guide.
Absolutely. And there are different types of care, right? So for example, if it's a simple matter of knowing what the new medication dose is for a medication, you might not, like, AI can give you that pretty quickly, right? Chat GPT, you can put that in and say, what's this new dose, and what are the contraindications, and how do I titrate, and all these other things. Whereas if it's, a procedural specialty, right? So if someone needs to get an operation done, or if they need to get an injection, or it's some other procedure, I think on the procedural side, it's going to be, we're a long way away from robots doing, surgery independently. Yes, I know we have a lot of these ideas about, and we have seen remote robotics and stuff, but think about how do you scale that? Like, scale is going to matter. You can do that once in a blue moon, but you have, the 2 million people in Ontario that don't have access to a family doctor, a wait list of close to 300,000 people on the list for a procedure, right? And so I think, to your point, the shepherding of information and the custodian of some of that information is going to be part of what the physician does, and accessing it through these new technological designs or innovations is going to be part of your competence moving forward. That's going to be part of your competency. And then probably what will happen, I think, is the college, so the regulator, right, will probably demand that you have a competence in this area to be kept up to date. So when we have, like, I'm sure you have this in accounting, which is sort of continuing medical education, it's not going to be necessarily about the latest and brightest. It's, do you know how to access that? And do you know how to leverage that? And do you know how to use access to that information to then improve your patient's quality of life?
Yeah, we have a new competency map in the CPA profession, and we call that evergreen learning, and sort of emerging technologies and sort of understanding, even being able to look under the hood of those technologies is a critical part of being competent. So totally. Okay, we got some good questions here. So I don't know if you can see the chat, Adam, but Mary A has a question. All right, let's go with Noreen first. How to leverage the power of AI with the power of the physician who is sitting with the patient.
Yeah, I mean, I think so. Kind of just what I think we'd alluded to a little bit, which is to say that I think that patients want some of these following things. I think they want access, they want convenience, they want high quality care, and they probably want it for a cost at a cost point that makes sense for them as a taxpayer or as an individual consumer of healthcare services, and so and different patients might want different things, right? So if you go to a doctor, some people just say, just give me the diagnosis and give me the treatment. Some people want to have a conversation. Some people want to care about bedside manner, or like, so these are types of things that are the qualities and the character matters. And so how do you leverage AI? I think if AI can take away or streamline all the back end stuff for clinical operations. Okay, so your booking, your follow-ups, your referrals, your auto scribing, I would love to be able to imagine even a prescription. So if I'm like, okay, it's patient X, this is what we're going to do. I'm going to prescribe you duloxetine 60 milligrams daily. You're going to take it once a day for the next month. We're going to follow up with you. And imagine as I'm doing this, the EMR with the AI auto scribe is already filling out a prescription and sending it to the pharmacy.
Yep.
Right. So I don't even have to then spend another 5 minutes writing a prescription or putting on, clicking on a bunch of different buttons on my EMR to send the prescription to the pharmacy. Imagine all that was already automated. So I think all the back end automation for some of the admin and sort of non-clinical, the clerical non-clinical stuff, that's going to be huge. It's going to be unlocking a lot of other opportunities for better healthcare, I think.
Yeah, and in accounting, we were calling those the rote tasks. Let's get rid of the rote tasks that we can automate, and then we can focus on the human skills and values that people need, and we can add that. Michael, can we unmute Mary? She's got a long question there. Maybe I'll try here. Not sure if we can, but in the meantime, well, we were trying that. Can you see the chat, Adam?
On my phone. Yeah, let me see. Actually, I can. Yeah.
Yeah. So let's say, Mary, when you talk about intervention methods and being proactive.
Why is the USA a reference points for the intervention and preventative health care? Thanks for the mention. You're trained, by the way. How are Canadian doctors being trained to use the latest? These are multiple questions, which I'll try and get to. What system is there politically to integrate these latest technologies? We hear about hyper future change. What will occur? What steps? Make sure that there are checks and non-replication of bias that's currently present. So that's there's a lot there. I think broadly speaking, I would say that our proximity to the United States gives us a bias for our consumption of culture, of media, of technology, of innovation. Our proximity allows us to be more aligned culturally with the United States than probably any other country. Our economies are intertwined. Our supply chains are integrated. Our families live in both countries. We speak the same language. There are so many cultural aspects of the United States that are so intertwined with ours that decoupling I don't think will ever happen. In fact, I think as you're starting to see friendshoring and sort of this the geopolitical challenges that we're facing international, I think you're actually going to start seeing those cultures even come back together even more closely, because there's sort of this, where it used to be this globalization, you're seeing sort of a trend of the opposite a little bit now. And so necessarily then we're going to continue to have an exchange of information and knowledge and dialogue between the border. And so I think our two countries, our two cultures, our two sort of competencies are going to come closer together as we sort of lean into each other's sort of well-being and sort of geopolitical closeness. In terms of why, so and I will still say that I think the United States is still probably the exporter of the most powerful innovation in the world, in many sectors. I still think that that's true. That's not to say that other jurisdictions and countries aren't, but look, Chat GPT came out of the United States. All of the last FANG and the tech companies came out of the major ones came out of the United States. Most of the medical innovation that's happening on research and development is happening from the United States. But that doesn't mean that other places are not going to continue to see a rise in their influence. I think geopolitically, there's a lot of this talk about, the United States being sort of an empire in decline, and you see seeing the rise of China and seeing the rise of the East, and so that I think is going to continue to play a big factor. But just our proximity and our ease and our access, right? So here's another example. I think the best comparable healthcare system to ours in the world is not the United States. It's not anywhere in Western Europe. It's actually Australia, in my opinion. I think Australia is, if you're looking at a country that is similarly sized, similarly spans similar geography as far as like its diversity, has challenges, has a similar education structure for healthcare, is slightly organized a bit differently, but I would say as a population size, geography, system, Australia is probably the best comp. Now, Australia has, a parallel system. It has blended models. Part of the reason why I believe that's the case is because they're an island, right? People can go down to Buffalo or go to Bellingham and cross the border and drive down to Mayo Clinic and get care if people need from here in Canada. And in Australia, you can't get that, right? You have to get on a flight and fly to New Zealand or somewhere else, and it's very, very remote. Why do I say this? Is that innovation, so we talk about innovation technology and AI and Chat GPT and predictive models, but we also have to think about innovation on policy. And we have to look at other places where policy has been developed that we can adopt potentially in certain ways that would be valuable for us. And this is sort of where, we need to start thinking about a bit more deeply. Let's not just be blinded by this massive sunshine that comes or darkness that comes from the United States. Let's start to look more broadly.
Absolutely. And Mary, does that answer your question? And Noreen, I think we're good. Michael, did you have any questions?
Yeah, I have one question, Adam. I really enjoyed your talk. And I think, a lot of what you said is really applicable to other industries and this idea of scarcity of resources. How do you show the value? How do you convince the government to invest in data strategy and AI in healthcare? Is it, is it at the OMA level? Is it tax? What is the next step needed so that we can really leverage AI in healthcare?
Yeah, I think it's probably a combination. And this is sort of just a personal philosophy. I think private and public partnership of initiative is sort of where things may need to go. And I'm a centrist. I believe in compromise. I believe in collaboration. I believe working across the aisle. I believe that, that these things are sort of where we can build our best work and our best path forward. And it's not an all or not, it's not an all or nothing thing. It can't be all private enterprise and it can't be just public sector. I think if we have either of those philosophies, I think we fail. I think there's a couple of areas there. On the one hand, I think that the private enterprise will, in private sector, I think is nimble, is focused, and has the ability to adapt so quickly to this such a very quickly adapting area. And you're already starting to see that, right? You're starting to see innovation and technology, and AI in Canada has been such a driving force, whether it's with the Vector Institute and Hinton and U of T and just AI as a sector should be thought about as an economic value add for our country, right? We should look at it as a key critical sector, much like we look at mining and energy and telecom and whatnot. We should look at AI as one of those types of things. And so I think on the policy side and on the government side, you say, look, this is going to create jobs. We're going to be a leader. This is going to be a place where if companies can come and invest. This is a place that we're going to be able to have an exportation of our knowledge that will have an increasing impact on our domestic GDP. I think on policymakers, you make the economic case. You make the case that this is something that for 10, 50, 100 years from now, this is going to be an engine for economic development and business development and growth in the country that we need. Right? We talk about stagflation. We talk about our economy not growing. Or concerns about that. Well, this is going to be a driver of that. So that's how you get the economic conversation going, and that's how the governments are going to be, continuing to hopefully pay attention. And then the private sector will sort of lead the charge initially, the early adoption, the new technologies. We have, these sort of cottage industries of companies that actually have now integration. So for example, there's a company that's trying to do the back end thing that I was telling you about, but that's like a home local grown company that's built the technologies, now deploying it in sort of clinical assets, or at least they're trying to help with that work. So empower the environment, meaning create the conditions for success, both from a business and a policy perspective, get all the data and governance and law and legal structures out the way, meaning do it now and do it fast and make sure it's right as best as you can, and tinker, but then bring that investment to a place where it can actually be deployed, in a marketplace where the go-to market's actually very quick, and where the interfaces are is somewhat more in close proximity.
Okay, thanks. And we have a question from Rodrigo there in the chat. Adam, if you can see it, about the new medical school, how to train new doctors.
I'm on my phone.
Oh, that's okay. I'll read it. As someone enacting a new medical school, how do you think training of future doctors, that is young people more familiar with emerging technologies, will have to change? What is the key point going forward? Are there any ethical / other concerns for us young, potentially over relying on AI for solutions?
Yeah, I mean, I think certainly let me try and mitigate the risk. So, for example, let's say your chatbot, your Chat GPT, didn't give you the proper differential diagnosis, or gave you the incorrect medication dose, and all of a sudden you kill the patient because now you gave them a wrong medication at a wrong time, didn't think about the contraindications and all those things. Now those things will be finessed, but those are these are risks, and so we have to recognize that the impact of a bad outcome could be potentially devastating, right? So an error here is probably at a magnitude of impact probably greater than in perhaps other sectors. Oh, you didn't get your Amazon box on time, or went to a different address. Well, that's different than maybe not getting your medication on time, which you needed because you were dealing with an infection, and skipping of an antibiotic, blah blah blah, right? Worsens all those types of things. So I think recognizing that, trying to get it right as best as we can and as quickly as we can, but doing it in the right way is going to be very important, because the risks are higher, perhaps, to life and limb for individuals. So the stakes are higher. As far as physicians and how do you train them? Yeah, look, I think medical education is, and will continue to be, completely overhauled. I will tell you, I don't remember any of my organic chemistry that I did in college. Like very, very, very little of it. But I remember slaving over it, and I would have much rather I would have been way better suited probably now learning about accounting, or learning about how to run a business, or learning learning coding than maybe organic chemistry, and that's not just, or chemists and organic chemistry, very, very important if you want to be a chemical engineer, possibly, right? But I don't know if that's necessarily as relevant if you want to be a physician. So I think what we're starting to see in a lot of ways, and this is sort of where I think, look at Ontario, and you're seeing how they're leaning into kind of the skilled trades, right? I think you're starting to see a condensation of the importance of very applicable skills. So what are the actual skills you need to be a physician, or a nurse, or an electrician? Is an electrician doing like plant biology? Probably not, right? And probably they don't need to be doing that. So how do we condense and fine tune and tailor and make our education system a bit more bespoke for the fields in which our graduates are going to be operating and practicing it?
Yeah, that is, again, from all professions, that is exactly the dilemma we're facing. And I'm just thinking, Michael and I have talked about this, but I think we're going to have a panel discussion across professions, because I've sat in on many talks from lawyers and doctors and other professions, basically saying similar things. There's this large body of knowledge that keeps changing, and we don't remember all that stuff unless we're using it every day. But these other sort of competencies and skills that we do need, those are the ones that last, that carry forward, right? And amongst those, increasingly, it's the ability to deal with data,
Sure.
be sort of continuing to learn and upgrade ourselves on using the new technologies. If there's no other questions, I know that everyone's busy. I just want to say this has been an exceptional talk. And you are an exceptional individual, Adam. And just keep doing what you're doing, because you give us hope. You're sort of a shining example of someone who is using their technologies to move things forward and change things, understanding that the systems within which we operate, sometimes they're not changeable, sometimes they're immovable, but finding new and creative ways to move through that. So thank you. And let's keep in touch. And if we do have a panel, we're going to be inviting you back to sit on that panel and maybe have
Absolutely.
some conversations with lawyers and accountants and,
Absolutely. Well, we have a lot to learn. Listen, physicians have a lot to learn from so many other disciplines and professions, and I'm happy to be a participant or just a learner in that environment. So thanks so much, Irene, for the invitation. Michael, thanks for organizing, and looking forward to connecting soon.
Thank you so much, Adam. And this brings our session to a close. Adam, you just mentioned something about prompt engineering and the importance. And on June 22nd, our next session is going to be given by Microsoft on that very topic of prompt engineering, how to ask the questions of these generative AI models so that you can get the information that you need. With that, thanks everyone, and special thanks to Adam, and we'll see you next time. Thank you.
Thanks everyone.